Good evening to all of you. It has been a pleasure to interact with all of you and just take you through how the nephrologist gets benefited by his interaction with the laboratory. So, if you ask the question as to which specialty deals with the most challenging cases, this question was asked and then it was analyzed. The Canadian study where they analyzed the challenging cases of more than 2.5 million patients, and they gave marks to the complexity of the clinical situation. And the various challenges that they grouped were clinical challenges, emergencies, risk of mortality, length of hospital stay, number of drugs, and also long-term care placement. And there are no prizes for the guesses. You can see that nephrology stands head and shoulders above the complexity of cases when it comes to clinical decision making and diagnosis. So it is not humanly possible to make a diagnosis without a lab support. And this is where the nephrologist's interaction with the laboratory is all important. And how a final diagnosis is reached in nephrology, you can see in this slide. You take in every patient that you interact with a good history. And a good history will lead you to a 30% close to your diagnosis, because you'll be including and also excluding certain diagnoses. So even in this era of internet, in this era of advanced electronics, there is so much to be said about the history taking. So don't forget and have a good base of history taking, because whatever done without a good basement is going to be a failure. So in the history taking, as far as the nephrology is concerned, you will start with not only from the patient's mouth as to how it all started, you will also talk to the patient's attenders and also go through all the records that the patient has till now, all the health records that he has. Why I am saying is that many of these renal diseases can be traced to the alternative routes of management, alternative routes of drugs, alternative drugs. All these can produce renal disease. And when you, after a good history taking, you go on to a physical examination, and a thorough physical examination will lead you to make 50% of your diagnosis. But mind you, laboratory help is extremely important to make the rest 50% of your diagnosis, because there is a big slip between the cup and the lip, and if you are not adept at utilizing the laboratory, you are likely to miss 50% of your diagnosis in nephrology. And this is where laboratory comes in very, very crucial. And there are as very 11 syndromes in nephrology, starting from the acute nephritic syndrome, which is commonly seen in children, but in adults too, it is becoming common because of increasing infections and infection-related glomerulonephritis. How does laboratory help in diagnosis? So in the acute nephritic syndrome, if you find that in the urine analysis with the help of a microscope of the sediments. If you find that there are RBC cast, then your diagnosis is coming closer. And after that, you make the laboratory investigations in the form of complement levels. And if you find that the complement levels, especially C3 levels, are low, and then you make a good diagnosis of nephritic syndrome, which you will have to make a final diagnosis with the help of your nephropathologist by doing a renal biopsy. The second medical semi-emergency is rapidly progressive glomerulonephritis. This can happen in any age group, and in young age group, it is most commonly due to diseases like lupus nephritis and other immune complex nephritis, and also diseases like Goodpasture syndrome. In the elderly, commonly it is due to vasculitis. So here, again, laboratory support is very, very essential. Beyond the point, when you make a final diagnosis, you require serological investigations in the form of anti-neutrophilic cytoplasmic antibodies and anti-glomerular basement membrane antibodies. Both of them are being routinely being done at Meenakshi Labs, and we are quickly we are able to get the reports so that we make a final diagnosis. The third major group of patients or the nephrotic syndrome, wherein the secondary cause, a diabetic patient with a nephrotic range of proteinuria, is a common diagnosis. So here we would like to do laboratory tests to exclude diseases like membranous nephropathy, where antibody testing for phospholipase A2 antibodies are being done. Then another major group of diseases are acute kidney injury, and in fact this is a real emergency that a nephrologist faces. This is like an acute kidney attack, just like how an acute heart attack makes the cardiologist be on his toes. In the same way, nephrologist is kept on his toes due to acute kidney injury. So we shall see in a clinical case scenario how laboratory support is very important. Then you have the chronic renal injury or chronic kidney disease, urinary tract infections, renal tubular dysfunction, because kidneys are the seat of adjustment of volumes, adjustment of electrolytes. So if you have this electrolytemia, you will have to have a close watch on the renal dysfunction. Hypertension. Most of the causes of hypertension are essential, but a large important chunk is due to renal hypertension, urinary tract obstruction, and urolithiasis. All these you will require good lab support. So this is the case vignette of a 70-year-old man who was admitted with altered sensorium 1 week ago. He has fever, oliguria, is clinically volume depleted. He had a skin rash in the legs where a dermatologist was involved in the skin biopsy, which showed vasculitis. There was no neck stiffness. Nephrological investigations included urine analysis, and there was no protein. So when there is no proteinuria or there is no albuminuria, there are certain diseases which you can exclude. A major chunk of the glomerulonephritis you can exclude. Bland sediments again tells you that it is likely to be acute tubular necrosis. The urinary sodium. So we do, with the help of the lab, urinary electrolyte profile, not commonly available in the other labs. So urinary electrolyte profile tells you that this patient is losing lot of sodium in the urine. Normally, in a volume depleted situation, the urine sodium should be very, very low, as low as less than 10 milliequivalents or even less than 5 milliequivalents per liter. This patient's urinary sodium is high, telling you that the tubules are not able to conserve sodium. The blood urea and serum creatinine were very high, and the serum potassium was 5.4. A serum bicarbonate of 15 with a high anion gap tells you that there is a metabolic acidosis. So metabolic acidosis is a common accompaniment of acute kidney injury because the retained acids are not excreted in the urine. Serological investigations are also important in acute kidney injury, which can take the form of serological investigations for infections. So we have in Madurai a good number of patients with acute kidney injury secondary to scrub typhus. It is a diagnosis which is easily missed, and sometimes it cannot, the mite bite or the sugar bite, which is typically shown in the textbooks as skin ulcer with an HR, may not be seen. So scrub typhus is a diagnosis which you make with the help of a laboratory, and it was positive for this patient. But the CPK levels were very high. He also had very high levels of antibodies to COVID virus. So you have a conglomeration of multiple infections, which is again very common in the southern districts of Tamil Nadu. I have found that a patient need not have only one type of infection. They may have co-infections with multiple microbes. So scrub typhus was positive. COVID antibodies were positive for him. The D-dimer, again, these are all laboratory investigations which are not available in all the labs. So we have all the gamut of laboratory investigations which will help in the decision making, diagnosis, and also therapy for the clinician. So D-dimer levels are very high, and with the help of a automated blood culture system in our lab, we made a quick diagnosis of E. coli septicemia, and also we made the diagnosis that the E. coli was a ESBL producer. So all these were possible with the help of a lab support, and he had final diagnosis was made with an AKI with multiple infections and inflammatory syndrome. And initially we started him after the scrub typhus antibodies were positive with doxycycline, and later we added on meropenem because we realized that he had E. coli infection also. And because of the renal failure, we took him for the conventional hemodialysis, but his blood pressure came down and he became hypotensive, and so we started him on the continuous renal replacement therapy. Again, this form of therapy is not available in many hospitals. We have been providing this CRRT for the past 25 years. So we have a very large experience, and the different types of CRRT that we have are the continuous veno-venous or the continuous veno-venous hemodiafiltration, which is now the most popular form of continuous renal replacement therapy. We also provide a specialized type of dialysis called regional citrate-based CRRT. This is especially helpful for a patient in the post-operative stage where you cannot give heparin, because heparin-based dialysis can produce a bleeding risk, whereas if you infuse citrate, which will chelate the calcium and prevent blood coagulation, especially at the regional area, at the area where the blood is coming in contact with the artificial membrane, that is the dialyzer, and then the citrate is taken off and calcium is infused. So this is a very specialized form of dialysis that we are providing, and we are one of the pioneers in India which provide this regional citrate anticoagulant based dialysis. And so we keep the ionized calcium target very low at the area of the dialyzer, and then once the blood comes out of the dialyzer, we provide calcium gluconate infusion. So over a period of 5 years, we were able to provide the overall survival. More than 50% of our patients had a good survival of patients with multiple organ failure. The case number 2 refers to a female who was admitted with fever and seizures, was treated as a TB meningitis outside. But again, don't go by the diagnosis made by another hospital. Always think in a separate way and think independently. And if you think independently, then it is likely that you will make a correct diagnosis. Then also do a thorough physical examination. Even though in India, because of the dark skin, we may be missing many cases of lupus butterfly rash. If you see very carefully, even in brown or dark skin, you will be able to make out the faint butterfly rash. So we made out this faint rash over the face with areas of alopecia. So a diagnosis was almost confirmed that this is not TB meningitis, but it is lupus meningitis or lupus cerebritis. And we checked from the lab anti-nuclear antibodies and anti-double stranded DNA, and all these came positive. The complement levels were also low, and a kidney biopsy, our nephropathologist confirmed that it is a lupus nephritis class 4. So again, with the help of a laboratory and also the ancillary services, we were able to make a diagnosis. And renal biopsy based therapy was provided. We gave mycophenolic acid and steroids. The proteinuria and renal failure reduced. Patient made a good recovery, but after 5 years during the first pregnancy, there was a flare-up, and she was treated with high-dose corticosteroids and MMF after delivery, because you cannot give MMF in a pregnant woman. So, and then she made a good recovery. The third patient is about a 65-year-old female who had fever, breathlessness over 3 weeks. She was treated as viral pneumonia. So anybody with fever and breathlessness over this COVID period, the first diagnosis that we make is COVID pneumonia. But again, not all glitters is gold. Always make an independent thinking and independent diagnosis. Her blood pressure was 160/90. She had a creatinine value of 5.5, and urine proteinuria had 3+ with bland sediments, and C3 C4 were normal, and she had normal sized kidneys. So we made a diagnosis of possible rapidly progressive glomerulonephritis, and with the help of a renal biopsy and a nephropathologist's help, a pauci-immune glomerulonephritis with crescents were made, and we checked the serology for antineutrophilic antibodies, and they became positive. It was PR3 ANCA positive, that it is a microscopic polyangiitis. She was treated with cyclophosphamide and steroids. She made good recovery and she is on follow-up. Case number 4 is about a female who had pedal edema and anemia, and she was treated as anemia with failure. But when we saw her, we thought that there were some signs of deposition disease in the form of multiple myeloma, because there was a albumin globulin reversal. And we did the free light chain assay, where the light chains kappa and lambda are differently assayed, and if there is a disconnect between these two, so this free light chain assay is not available in most of the labs, and it is available in our lab. In the Meenakshi Labs, we have this routine assays being done, and we make a diagnosis even without a renal biopsy or of possible monoclonal form of myeloma, and multiple myeloma with cast nephropathy was made. The fifth case is about a 34-year-old female who was admitted with a quadriparesis. Initially, again, the diagnosis label which we received outside was she had Guillain-Barré syndrome. But when she came here, the laboratory investigation showed that she had severe hypokalemia and also a normal anion gap metabolic acidosis. Normal anion gap is between 8 to 12. You see here that the anion gap is only 8 and the serum bicarbonate is so low. It tells you that either there is a bicarbonate loss in the gastrointestinal tract, or there is a bicarbonate reclamatory problem and acid excretory issue in the renal tubules. So because this patient never had any diarrhea, the most possible diagnosis is renal tubular acidosis, and we did what is called a urinary anion gap, which again showed us that the patient had a positive urine anion gap, which indirectly tells you that the ammonium chloride excretion is very low. When ammonia is clubbed with hydrogen ion, ammonium chloride is formed. So when there is no hydrogen ion excretion, then the ammonium chloride cannot come out, and this tells you that there is likely to be a renal tubular acidosis. And the common cause of renal tubular acidosis in our population, especially in adults, is Sjogren's syndrome. And again, in our labs, we have what is called an ANA profile. A large number of antibodies are being tested. More than 20 antibodies are being tested, and we make a diagnosis. So this patient had an anti-SS antibodies, ANA was positive, anti-dsDNA was negative. She was ventilated, intravenous potassium and steroids were given, and her power improved. She walked back home. So telling you that in every little step that we take in the diagnostic and also therapeutic maneuver, Meenakshi Labs have been a great help. So starting from this urine analyzer, which tells us about the variety of urinary electrolyte profile, the hematology analyzer, which tells us about the variety of hematological changes and the clues that it comes out from this hematological workup of a patient with renal disease, and the coagulation analyzer, where even individual factors can be analyzed, and also in a patient, for example, in a pregnant lady with what looks like a preeclampsia, if you find that the patient has features of advanced coagulation defect with liver cell failure, you make a diagnosis of the acute fatty liver of pregnancy. So all these are made possible with the help of a laboratory, and this is the flow cytometry which we make good use of in diagnosing not only different types of blood hematological blood dyscrasias and also therapy, along with the T and B cell based flow cytometry for donor and recipient matching before a kidney transplant. We also have a fully automated blood culture system which makes a diagnosis of the type of organism which is growing very quickly, and a fully automated antibiotic sensitivity system. So instead of thinking very deeply without any clues, we in Meenakshi Hospital are able to make quick diagnosis with the help of this laboratory support, and we leave no stone unturned, and we do everything possible to make the final diagnosis so that the patient goes out with an improved prognosis, his life is saved. Thank you very much for patient listening.
Good afternoon or good evening, everybody. And it was a nice session with respect to the nephrology from the how the laboratory services can be useful for the nephrologist, as well as the session on South Tamil Nadu renal diseases, or the prevalence, or whatever studies are being done here. So we have got a very important insight with respect to the laboratory investigations as well as the spectrum of the renal diseases in South Tamil Nadu. So I am very thankful to both the speakers for giving their valuable time and sharing their knowledge with us. I am also thankful for all our participants who has participated as an attendee in these sessions and waited for the complete seminar webinars, and they have attended both the sessions. So it is very thankful. I am very thankful for them. And also I am thankful for the management for arranging this type of webinars on regular basis, so as to share our knowledge from our eminent speakers for our all referring doctors as well as students, PGs with the respective specialties. So thank you all, and thanks for attending the session. Thank you.